about the treatment of pain associated with pancreatitis, which I guess is a very hot topic.
Yeah, let's, thank you very much. Let's just get this going and now, first of all, can I say that I'm really thankful to you all and to Mr. Westgate for having asked me to come to your meeting. And it's a great privilege to talk to you all about the treatment of pain in chronic pancreatitis. Well, just before I just want to sort of touch briefly upon the normal or physiologic function of the pancreas. Essentially, it produces digestive enzymes to help us digest the food that we eat, and it also produces a lot of hormones. The difference between enzymes and hormones is that enzymes are released into the bowel and they act inside the bowel, whereas hormones are released into the blood and they reach various parts of the body and they act remotely. So insulin, which is a very well-known hormone secreted by the pancreas, acts at various different organs, including the liver, the muscle, and various other places. So these are the two main functions of the pancreas. Now, what is chronic pancreatitis? It's essentially progressive and irreversible damage to the pancreas. That's the most important thing to know about chronic pancreatitis, that it is progressive and it's irreversible. So, I mean, given the fact that it's progressive and irreversible, how are we going to deal with this problem? Essentially, it is a chronic illness. It's something like, for example, diabetes. You can't really cure it, but you've just got to sort of, develop a symbiotic relationship with the problem and get on with it and do as much as possible of your normal life that you can. Now, chronic pancreatitis is caused due to various problems. External triggers, mainly alcohol, and idiopathic, which basically means that we don't know what the cause is. That's what it means. We don't know what the cause is. It forms a fairly large chunk, 20%, 1/5, and then 10%. These are the really rare causes, like hereditary pancreatitis. We've got a lot of patients here up in the north of England who've got hereditary pancreatitis,
and some here tonight.
Yeah, and that is actually a topic of intense investigation now, because number one, it gives us a model of how the pancreas, develops this chronic inflammation, and number two, it provides us with the ability to screen for the illness in people whose pancreases we know are normal, and in whom we think that in future they might end up with the problem. So we get to know a lot about this illness by studying these patients with hereditary pancreatitis. Now, pain, we know, is one of the cardinal features of chronic pancreatitis. I'll talk about that a bit later. Maldigestion, which is another very big problem. People end up with significant symptoms and ill health because of maldigestion, mainly because the digestive function of the pancreas is improper. So one of the two main functions, which we just talked about, that goes kaput, and so you've got maldigestion. And you've got diabetes, which is the next problem, which is because of the poor hormonal function of the pancreas. So the insulin which the pancreas secretes, gradually begins to go down in quantity and quality, and there is this problem of diabetes. Now, the pain in chronic pancreatitis is actually one of the biggest problems, and so I'm just going to elaborate on it further before I talk about its treatment. I mean, we can treat diabetes well with the insulin, and very soon we are probably going to have islet cell transplants in the probably 10 to 15 years, so you can have a few injections of islets and then diabetes can nearly be sorted. It's actually well on its way. In probably about 15 years' time, you'll have islet cell transplants. And the poor digestive function of the pancreas can be easily treated by, we've got wonderful dietetic supplements and replacement of pancreatic enzymes, and you can take that and you can nearly correct the nutritional problems completely. But the pain which chronic pancreatitis brings about, that is actually quite significant. Now, tissue damage in any part of the body brings about this response, activation of the nervous system in the peripheries, which is basically the nerves and the nerve receptors, and then it goes along to the spinal cord, which is the first relay station, and then it goes up to the brain, where it's perceived as pain, and then the various qualities of the pain get added onto it, and then then the human body knows that there is pain. Well, why human body? Any living organism knows that it's pain. And this reflex is present because to prevent ourselves from tissue damage. So the pain is actually a defense mechanism. Now, it goes from the peripheral tissue to the cells which are present in the nerves, and then goes up to the spinal cord. And then in the spinal cord you have the first relay, and then the pain receptors go up to the brain, where the finer qualities of the pain are actually integrated. They've done various studies in animals in days before the various laws regarding cruelty towards animals were enforced, and they used to cut off the spinal cord stem just below the brain, and they've still found that the animal would actually withdraw the leg if a noxious stimulus was applied to the leg. So it means that there is a reflex in the spinal cord, but the animal doesn't really know what or where it's coming from. It doesn't know whether it's coming from the right leg or from the left leg, or whether it's coming from the skin, or whether it's coming from inside the abdomen. So all the other qualities of the pain are actually superadded in the brain. So this is a bit of a complicated pathway. I don't think we need to go into that in too much of a detail. Now, why do we get pain in chronic pancreatitis? The first and the most important theory is that there is block to the ducts of the pancreas. There is a blockage there, and that blockage comes about because of the protein and calcium and the various secretions of the pancreas which become thick. And that's certainly one of the theories in which pancreatitis due to hereditary pancreatitis, and also due to an illness called cystic fibrosis, because the secretions of the pancreas become thick and they can't really go out of the fine ducts, and they actually block the ducts. And so there's pressure which builds up behind, and that pressure damages the cells. And if this goes on after for a long period of time, this blockage becomes nearly permanent in the ducts. And so whenever you eat, or which is the most important stimulus to the pancreas, the gland secretes enzymes, but there's no place for it to go, and the pressure inside the ducts builds up. And this is actually why the pain in chronic pancreatitis is so horrific and lasts for hours after the patient has even thought about eating or even smelt food. Now, of late there is this theory about free oxygen radicals. You all know about all these various micronutrients like selenium, zinc, and various companies marketing various things, and vitamin A, E, which are all antioxidants. And what are they anti against? These are the oxidants which are released in the human body, which actually damage the body, cause it to age, cause it to develop inflammation, cause it to develop various other diseases. And so this is another theory which says that, and which is true to a great extent, because we know that all these triggers worsen chronic pancreatitis. Now, this nerve damage because of chronic pancreatitis is extremely interesting. This theory has come about because, and has been proven of late, and there's been great interest into this problem in chronic pancreatitis, because pain of any other nature can be treated by using various strong pain medicines. But they found that pain due to chronic pancreatitis is actually quite resistant to the most potent pain medicines. Why is that so? And there have been various elegant experiments designed by various physiologists and biologists, and there have been changes which have been documented to develop within the nervous system, which I'll just tell you a little bit about in detail just after the slide. Essentially, which goes to say that because of these changes which occur in the nervous system, an organism feels pain even when there is no stimulus causing the pain. Sounds a bit sort of roundabout. I'll just sort of explain this a little bit further. You see, this is the nerve fibril which goes into the spinal cord, and then from there there's another relay which goes up to the brain. Obviously there are not one, there are many such fibers which go from here. So here we've got two fibers. The one at the top, in which there is the brown arrow, is actually the nerve fiber through which pain is traveling. This nerve fiber down below doesn't usually transmit pain. It transmits, let's say, vibration or gentle touch, because you've got different receptors for different senses and different types of sensations in the skin and in every organ within the body. So let's say there is a lot of pain stimulus going through that top nerve fiber there. There are only certain number of receptors there in the spinal cord. There are only 3 green ones there. What happens is, after some time, due to continued sort of impulses going through the nerve, the spinal cord nerve cell actually develops a lot of receptors. You can see that 3 is increased to nearly more than 6, around about 7. I mean, this is just schematic. I mean, so what happens is that the receptors increase in number like anything. This is actually called upregulation of receptors. This happens in every organ system within the body. And now what happens is that spinal cord neuron, the nerve which is the second station relay, becomes so sensitive that even if there is gentle touch here in this nerve fiber down below, this didn't have a brown arrow in the previous diagram. That's because there was no pain going through that. So even if there is gentle touch, the nerve, that second order neuron sends a signal up to the brain saying that it's pain. So even though there is no impulse going through this one, or there is minimal impulse going through the pain fiber, the non-pain fiber sends a message up saying that it's pain. So it's basically very simple to, most of us would have had an abrasion. And if a gentle breeze blows over it, you find that it burns like anything. If it's, and that's the analogy. Even though there is no damage going on, there is an area of abraded skin, and there is gentle air which blows over it, or you put cold water to clean it. It's just cold water, lukewarm water to clean it, but still there is an awful stinging, painful sensation felt there. That's because of central sensitization. This is because basically the nerve or the neurons have become sensitized. This concept is called hyperalgesia, and this is something which is more pain. That's what it means, and there are various words used with it, which says dysesthesia, which means abnormal pain. So even if there is no real pain stimulus going on, even if there is no ongoing inflammation in the pancreas, or a duct blockage, or free oxygen release in the pancreas, but still, just the fact that that there is normal secretion going on in the pancreas can actually trigger off pain, which is pain in inverted commas felt in the pancreas. And this kind of pain is not amenable to treatment with any pain medicine, because it's not really pain. It's something else. It's basically normal signals, nerve signals going through the nerve, which is perceived as pain. So this is an extremely difficult one to treat, and that's why we find that treatment of chronic pancreatitis pain and pain associated with various other chronic disease conditions are actually quite challenging. Now, just to briefly, I'm sure people who have had chronic pancreatitis, will know that the pain in chronic pancreatitis is actually the most bothersome symptom, because it compromises quality of life, and also it's got serious economic and social implications. You can't really do what you want to do because of the pain, and this is actually quite an important issue, is that to sort the pain out, we end up taking or prescribing, encouraging patients to take, and patients end up taking pain medications, and they go up the various stages, and then you end up taking loads of narcotics, which is opiates, morphine and various other things, and then you end up with the secondary problems of those. And because chronic pancreatitis, affects mainly the economically productive, the real breadwinners in the family, people who really work hard, who are looking to work hard, who are socially and economically productive, or in the prime, this problem is so much greater. Now, I'll come to that a bit later on. Now, I just want to touch upon the type of pain in chronic pancreatitis. Some patients may not have any pain at all. This is actually the burnt out stage of chronic pancreatitis. But more usually, we all know, pain is upper abdominal, radiates through the back, can be intermittent or continuous. And referred pain, why is it felt in the back? It's mainly because of referred pain. I've just got this picture here just to schematically show the heart and the way pain is felt in the arm, you see, because the nerve fiber coming from the heart and the one coming from the left arm, relay on the same neuron in the spinal cord. So this is what happens even with pancreatitis. That's why it's found at the top of the tummy and then radiates through to the back. Now there are two main typical patterns in chronic pancreatitis pain. I think it's quite important to know about these two because it will tell people who've got chronic pancreatitis, what is happening. Type A pain is actually, you can see, H stands for get admitted to hospital. So the pain gets so severe that people end up needing to go into the hospital. And then you can see that there are actually pain-free intervals. There are no sort of blue marks there. You can see people are absolutely pain-free. And now type B pain, when there is pain present always, so it goes up and down like that. And some days are good days, some days are bad days, and then there are really bad days when you need to get into hospital. Now, there is a reason why the pain pattern goes along like this, bounces up and down like this. Okay. Well, we just talked about this. Yeah. I'll tell you about why the pain goes up and down like that, but just to talk about the burnt out chronic pancreatitis pain, you've got to always remember that this is what happens. Continued exposure to the triggers of chronic pancreatitis causes complete loss of pancreatic function. The pancreas just completely, switches off, and there's no pain. Some people, are lucky enough to have this, but you've always got to remember that continued exposure to the triggers causes continuing inflammation. But the pancreas is completely switched off. That's why you've got no pain at all. But you've got a 3-fold increase in the possibility of complications, which basically cause type B pain. The type B pain, when you've got continuous pain, so you have a period of when you've got no pain at all, and then suddenly the pain comes back with a vengeance and stays for weeks or months. That's when you've got a complication from the chronic pancreatitis. So this is the important thing to recognize. So after a relatively pain-free period, you've got pain which carries on for weeks and months. Then there is something going on in relation to the pancreas, like there is there can be cysts developing with the pancreas, or there can be a narrowing of the main duct of the pancreas, which is not letting anything pass through. So we know that. Because as we've talked up to now, I've just tried to touch upon the causes of pain and the different pain patterns and why you've got to recognize type A and type B pain. And now I'll go on to the treatment, but just before that I thought I'd just sort of reiterate these few points which I think are quite important. That the cause of the pain is complex. We really don't know why pain in chronic pancreatitis happens. We've got a few ideas, and we can tailor our treatment based on those. Sometimes they work, but we know that there can be changes within the nervous system which may make the pain resistant to various different traditional modes of treatment. Now, the basics of chronic pancreatitis pain treatment. You've got to prevent type A pain. We've got this here. How do we prevent it? Basically, by avoiding the triggers. So, avoiding alcohol, which is the most important trigger for chronic pancreatitis. It doesn't matter what the initial cause of the pancreatitis was. It doesn't matter at all. Because alcohol can cause an inflammation within the pancreas, you just got to completely avoid it. And what that does is that stops people from getting type A pain, these pain episodes. So then you stay up on that as much as possible. So that is the most important thing to do. Obviously, when the pain gets too worse, you need to come into hospital, when things go up like that. But there are a few episodes here which can be treated with simple drugs or various other kinds of treatments, which I'll come to in a minute. So basically, we treat episodes of acute pain conservatively, and when type B pain happens, we know that there's a complication, and so we've got to treat the complication. I'll come to that in a minute. So these are the main sort of pillars of treatment of chronic pancreatitis pain. We've got to avoid the triggers, got to treat gallbladder stones, got to control elevated lipid levels. These are actually two important things which I left off until now because I mean, these are the two main things which we usually look for in anybody who's got chronic pancreatitis. Because like I said about alcohol, gallbladder stones can be a trigger for somebody who's had chronic pancreatitis from some other cause. So we usually treat the gallbladder stones in patients who got chronic pancreatitis, either during or after an episode of hospitalization with problem related to the pancreas or not. So an ultrasound scan of the abdomen, which most patients who come in with chronic pancreatitis type pain have, is usually we're actually looking for gallbladder stones. Sometimes gallbladder stones are like small coral. They are not seen on when they're very, very tiny, and they continue to form. So you had a scan now, and 3 years later you might be able to see a gallbladder stone which was not seen on the earlier ultrasound scan. That's the importance of, I mean, a lot of patients ask me, I just had the scan just 6 months ago, you're not doing anything for me, you're just getting a scan done. But the importance of the scan is that it picks up gallbladder stones. That is actually an extremely important bit of information to know. And treating elevated lipid levels, because we know hypercholesterolemia and increased triglycerides in the blood can actually set off inflammation within the pancreas. So, and a lot of people, and I know at least 3 or 4 who come to us at Freeman who had chronic pancreatitis because of elevated lipid levels, absurdly elevated lipid levels, and that happens because of some problem in the metabolism within the body. So you've got to treat the elevated lipid levels and remove the trigger. And obviously, we know about complete abstinence from alcohol. We have had a patient who actually had a chocolate liqueur while she went on a trip to the continent. I mean, this is what Mr. Only has told me. I mean, I haven't met the patient, and she had such a nasty attack of pancreatitis that she needed to be admitted over there. So the amount of liquor in a chocolate liqueur, can't believe it, but can happen. Now, treatable complications are cirrhosis, narrowing of the main pancreatic duct, and duodenal obstruction. I mean, there are patients who have had these various complications, and patients need to be admitted to a hospital for these to be treated. Now, coming down to the main drugs which we use, basically pain-relieving medications and suppressing pancreatic secretions. Okay, here we are. Now, simple analgesics. These are mainly paracetamol, based compounds, and ibuprofen and lansoprazole and the acid-reducing medications. And these are the ones which are usually recommended. And like we were just discussing earlier on, it's always wise to have a regular supply and have a regular schedule with which you take your pain medicines rather than wait for the pain to come on, at least during the type A kind of episodes. I mean, patients usually tell that they know when such an attack is going to come on. So just make sure that you have some simple pain medicines to sort of have on board. Opiates, unfortunately, there's nothing in between these two. And it's simple. You've got paracetamol and various other things which you can use, and then you've got the opiates, which are basically codeine, tramadol, morphine, and sort of oxycodone and various other drugs which you can use. And I mean, if we've just discussed a little bit earlier on, but if you want to ask me any questions at the end, I'll sort of tailor my answer to that rather than carry on about it. The next thing is about pancreatic enzyme secretion inhibition. This is extremely, extremely important. I mean, there are sort of various drugs like, we just talked about this, opioids. Okay, so codeine, tramadol, morphine, and oxycodone. These are the 4 main types of opiates, which are prescribed. And what I just wanted to put the slide on and say is that because we don't have anything in between these two, between paracetamol and codeine, tramadol, or morphine, it is a logical step for patients to go from paracetamol to these kind of pain medicines, and that's absolutely acceptable. It's not. I mean, if the pain deserves it, you will need to use one of these. But obviously, you need to make sure that as soon as that type A pain episode goes off, or once the complication has been treated, you try and get back to the baseline and get rid of these drugs as soon as possible. That's the most important thing, because there are a wide range of side effects of opioids. Constipation, drowsiness, nausea and vomiting. Nausea and vomiting is such an important problem. People don't realize that because it creeps up so insidiously. You begin to take some tramadol and morphine, the pain goes away, and then the weight drops off. And then you sit down and you talk to patients, and then you know that they've got nausea. They've completely gone off food. That's because of this large dose of opiates which are going on. They're actually relieving the pain, but they're actually suppressing the appetite zone in the brain and stopping people from eating, or along with that, or maybe without suppression of the appetite center, they're just making people vomit. I mean, people who've had a bit of morphine or pethidine in the A&E or down in the admitting suite at Freeman will know. You have the medication, and if there is even a 5-minute delay of cyclizine or metoclopramide or some other anti-sickness medication, you just bring everything out. It happens so commonly. And imagine what will happen if you're taking opiates regularly over weeks and months. It just stops nutrition and brings the nutrition level down to such a low level. And obviously, narcotic dependency. I mean, this is such a great problem that from one problem you end up, you get rid of the pain from chronic pancreatitis, but you end up, becoming so heavily dependent on narcotics that becomes a problem. Worse, if not equal, to the pain from chronic pancreatitis. So there is a role for opiates, but you've got to be extremely judicious where to use it and how much to use it, to be aware of the fact that they've got all these various problems associated with them. Now, what can we do about the central sensitization? Now, opiates are ineffective in its treatment. There's no use. You can give as much opiates as you want to, but the pain doesn't go away. And they can worsen it in various patients, depending upon the type of receptors patients express. Now, there is a role for what we call NMDA receptors. Those receptors which were in green in my earlier slide, they're actually this chemical receptors. It's got a fancy name, but it doesn't matter. And there are drugs which can actually block those receptors. So if you've got 7 of those green ones which have got the neurons sensitized, you can actually block a few of them using drugs like this. These are all very new ideas which people are using, and these are all still in the stage of stage 1 and stage 2 clinical trials. So there are no so it's not licensed really, but certainly there are a few anesthetists in our hospital who use them, and I know last year we have used it on nearly 3 patients, and it was wonderful, and it just gets the patient back to what they were doing, in such a fantastic manner. So it's always important to sort of realize that your pain might not be getting sorted with opiates, so there is a reason for it. So if you explore that reason, maybe we can find an answer for that. Now, pancreatic enzymes are extremely important to take to relieve the pain. There are various studies, but there's been no definite documentation that actually patients saying that the pain has come down. But probably because they improve the nutritional status, they help you absorb everything which you're taking in, and nothing goes waste, and nutrition improves, and you feel better and feel stronger, and maybe that has a big impact. Certainly, that's one of the reasons why we always ask patients, when they come back to us, or ask GPs to check on you all, or on patients, if they're on adequate doses of creon. You're on an adequate dose of creon if you're not having diarrhea. Even if you're having intermittent diarrhea, or if you drink a full cream cup of tea and you have diarrhea, then it means that you're not getting enough creon. So you need to take, and nobody can overdose on creon, and creon doesn't have any side effects. So creon needs to be taken as much as needed, depending upon the amount of food that we eat. So creon is extremely important. And there are all these various new drugs which are being used, including, there's a really fancy drug which is being used in the USA quite frequently, but not available here. But there are a lot of skeptics and a lot of supporters as well of this loxoglutamide, but it's not really known whether it's really useful because there haven't been any randomized scientific trials, and there are all these other various drugs which can be used. Now, I'm just going to talk briefly about nerve block procedures which are used in, I mean, this is the complicated nerve supply. Basically, this is the one which goes down to the pancreas from the spinal cord, and the principle is to actually divide that there, or divide these here, by doing what we call celiac blocks. I don't know if anybody's had any celiac blocks here, but these are actually quite useful. But the problem is that if you do it using a needle without it being done at open operation or being done endoscopically, I mean, having this done at open operation is an overkill, so nobody does them. So you can have it done through the back, and unfortunately the results are not, they're not sustained for a long period of time. So that's the main problem. So the pain relief is there, but it's usually short-lived. And you can have what we call thoracoscopic splanchectomy, where you have a keyhole operation through the back, and you have the nerves divided right up in the chest. Basically, these actually go down to the pancreas, these are these ones here. So you basically just denervate the pancreas. But unfortunately, nerves have a tendency to grow back and rejoin, and that's what happens. Or there are other pathways which we don't know of, through which signals from the pancreas and the retroperitoneum are reaching the brain. So unfortunately, there are sort of various proponents for this, and certainly they are worth a trial in patients in whom there are no complications, and all the complications of pancreatitis have been treated, and the chronic pancreatitis pain continues to be a problem. And there are various endoscopic procedures, like a big cyst in the pancreas, and that's the stomach there, which is actually completely compressed, and you put an endoscope in, that's the view through an endoscope which goes into the stomach. You make a hole into the cyst through that, and that's a balloon which we use to stretch the opening and put a pigtail catheter in, and you can see after a few weeks the cyst is gone completely. So this is what causes B-type pain. Somebody's had pain and it goes off, and suddenly after a pain-free interval there is sudden severe pain. It's usually this or this. It's actually a block in the main pancreatic duct. This is actually the duct of the pancreas, which you can see, and we've actually put a wire up there, and then we use a balloon to actually stretch the duct, and then put a stent in. You can see the stent here. So that's a pancreatic stent which has been put in, and this helps, and a lot of patients have great relief, and the stent usually stays in for quite some time, and with continued avoidance of the trigger for ongoing inflammation, the stent can be removed or sometimes stays in for a few months and then is removed. So this is another one where there is just one stricture. You see, the rest of the duct is quite healthy. This is something which can happen in patients with hereditary pancreatitis as well. So you just have one stricture, one dominant stricture, and if that's treated, the pain completely goes away, and then people come off all their pain medications which they're on. There's a wire which goes up there, and there's a stent. And now we've got a few surgical operations, but surgery is something which we use as a last resort because it doesn't usually solve all problems in all people. So patients need to be very carefully selected for an operation. And one of the common operations which we perform, which is quite successful in relieving pain, is something called Frey's procedure, which we've done quite a few of here. Basically, it involves taking off a bit of the head of the pancreas, which is where the inflammation usually is. So that's the pancreas there, which we have opened up completely all along. And that's the bowel, which has been divided there. So that bit of bowel goes on to that. And so what happens is that there is no blockage or to the pancreatic ducts, and all the inflammatory tissue, which really acts as an engine and keeps on driving this central sensitization and various other problems, goes off. Patients really do extremely well with this, and there are a lot of patients who actually become pain-free after such an operation. But obviously, there is still a remnant of the pancreas there, and there can be inflammation within that. And there are various other procedures which can be done, including removing the whole pancreas. That's a bit extreme because that makes patients develop diabetes, which is very, very difficult to control. and the operation itself is an extremely hazardous one. So because of the inflammation, it's actually one of the most difficult operations which can be done. So a pancreatectomy isn't really, I mean, all these procedures, they're not really ones which we will think of without sitting down with the patient and discussing various options very carefully. And there are various newer techniques. Spinal cord stimulation. There have been a few patients who have had wonderful relief. Basically, you get an electrode implanted into the spinal cord, and you have a small dial, which what happens basically is that there is a wonderful theory in this, is that you stimulate the nerves to such a great extent that the relay pathway doesn't transmit anything beyond it. So that's the basic idea. So, and there have been few patients who have had fantastic pain relief with this technique. So, and obviously this is another one which isn't, for which patients need to be very carefully selected. This one, cognitive therapy and biofeedback, this is finding a lot of supporters of late. This is basically something in which you use, you basically just sort of cope with the pain and develop this symbiotic relationship, and then patients find that pain, which was because of central sensitization, completely goes away. And this, I mean, this sounds a bit too far-fetched, but there have been various sort of studies in which this technique has been found to be of great help in disorders like irritable bowel syndrome and also central sensitization pain associated with pancreatitis. Obviously, it is a multidisciplinary team management. I mean, we like to use this word in the NHS and in medicine quite a lot, this MDT business. I mean, what does this involve? It involves the patient, and the patient is actually the most important team member. So without the confidence of you all and trust in the team who's actually trying to do something, this doesn't work. This whole MDT business doesn't work. And obviously that's why the patient is the most important one. And then you have these various other people. You know? So I just want to sort of summarize by saying that it is a challenging problem, chronic pancreatitis pain, and removal of the trigger is the key. That is the most important key. When chronic pancreatitis begins, you've got to get rid of the key. You've got to get rid of the trigger. The sooner you get rid of the trigger, the less the permanent and irreversible damage to the pancreas is going to be. Because that's what chronic pancreatitis is. Various options are available. Opioids are useful, but you've got to be really careful with them. You've got to treat them, in inverted commas, with respect. That's what I'd like to say. And there are various treatment procedures possible, which is where departments like us and hospitals like us, that's where we come in. So we actually come in quite low down, see. And the most important person who can make a big difference is actually the patient themselves. And that is the most important thing. Thank you very much. Another thing, which I haven't sort of clarified, I just sort of rushed through a few things, so I'm sort of more than happy to sort of elaborate a little bit or answer any questions.
Can you answer why, when they're brought into like accident emergency,
yes,
the only drug that they offer the patient is morphine?
Yes.
Now I've heard that morphine actually constricts the pancreatic ducts,
yes,
which is counterproductive in the control of the pain.
Yeah.
Because in my husband's case, pethidine's the best thing for him, but nobody seems to listen.
Yeah. I'll tell you why. Earlier, this was maybe...
It's okay, you get the Freeman, it's fine.
Yeah.
It's if it happens that the RBI just insisted on giving him morphine.
Morphine, yeah.
He was in a hospital in Belfast a few weeks ago.
Yeah. And they...
No, they gave him morphine first, but as soon as he went on the ward, they listened to him and turned to pethidine.
Yeah, that is actually one of the main problems is to actually, pain relieving medications during those type A kind of episodes, is actually different for different people. And in days gone by, there used to be this thought that morphine, does cause a spasm of the sphincters, at the end of the pancreatic duct and the bile duct. And maybe it does in a few people, But pethidine and morphine both seem to have similar efficacy. But because the receptors which pethidine acts on, they belong to the same family, but act on 1, 2, and 3, whereas morphine probably acts on, 3, 4, 5, 6. So if somebody, has got a predominance of 1, 2, 3 receptors, morphine mightn't act well on them. So they might need methylene. So this is something which is very difficult to sort of filter down, right down to sort of A&E and to acute reception units.
You understand when you come in, the first thing you want is pain relief.
Yeah,
yes,
I agree.
Take it.
Yes.
But once you get on the ward, say the 3 months is fine.
Yeah.
And just say pethidine and say, right, we'll give you pethidine. But my husband was in the RVI for 10 days.
Yeah.
And that was the illest he's ever been. And all they kept doing was topping him up with morphine. He wouldn't listen.
Yeah.
They kept saying, talk to Mr. Charnley at the Freeman because that's his specialist.
Yeah.
And they eventually spoke to him the day before he came out.
Yeah, that was probably after. Yeah, after.
He was so ill, he actually went yellow. He was jaundiced.
Yes.
The amount of morphine that we were giving him.
Yeah. I mean, this certainly does happen, and we've had. I mean, certainly I received phone calls from sort of various hospitals from various places when I was here a year ago, and I mean this does happen. Unfortunately, it gets so difficult to actually convey down to them. And maybe one of the things which I used to think of was just like people have got diabetes cards and various other kinds of cards, and maybe there needs to be something issued from the GP or something just to say that that I've got this problem and these are the medications which actually work for me, and have a card in your wallet. I'm sure it won't cost much. It just needs to, I mean it just needs to sort of trickle down, and I'm sure that can be organized, if you can have a small card and say, just like you have your regular prescriptions or something, because this does happen. But I mean, certainly I'm surprised as well that they didn't ring earlier and sort of have a chat with us, because it's just across the town.
We kept telling them, but they just wouldn't listen. He had so much morphine, he was actually tripping.
Yeah.
It was typical drug, he was pinpoint.
Did they check his liver function test and make sure that they were okay when
filling him full of morphine and giving him antibiotics, and that was all they checked him with for 10 days.
So is he going to come back to see us here?
No, unfortunately, he supposedly missed 2 appointments here, so he's been signed off. But he never actually got the appointments to come back.
Yeah, this happens a lot. I mean, they just got to get the GP to give Janice a call.
No, touch wood. For the last 2 years, he's only been admitted once, and that was just all I know.
Excellent. Hopefully he wouldn't need to go near the RVI again.
Well, I won't let him go near the RVI again.
The wife died, and the main cause of her death on the death certificate was pancreatic tumour. Now, you've never mentioned tumour, you mentioned cyst.
Yes.
But during our treatment, she said never had treatment, but during our visits here, it started off with a tumour and ended up with the pancreas being covered with cysts.
Yes.
Now, during that time, luckily or unluckily, she never had any pain. Indeed, she never gave me any indication she had pain until just a couple of days before she died.
So did she have a chronic pancreatitis? Did she have chronic pancreatitis?
No.
No.
As far as I know, she has a pancreatic tumour.
Right. Yeah. I mean, I didn't sort of touch on. I mean, chronic pancreatitis. I mean, if somebody's got chronic pancreatitis for a very long period of time, they can develop pancreatic tumors. But I didn't touch on that because that becomes pain treatment in tumors of the pancreas becomes a completely different sort of ball game. Because
she never complained of pain.
No, she didn't. Did she not?
And
No.
as far as I'm aware, when she first came to the Freeman to see Mr. Charlie, she had a pancreatic tumour. That was at the beginning. There was no build-up or anything as far as we were concerned, because she never, 3 years ago when we first had the initial meeting here, the secretary who was now ill, she was telling us her symptoms, and she was in a lot of pain. And the wife never had that.
The tumors certainly do cause pain, or they cause jaundice.
Our last few days in Shotley, she did develop jaundice.
Yeah. I mean, that's one of the problems with sort of tumors of the pancreas. They tend to sneak up. I mean, they're really, they're not sort of, they're not nice characters. They sort of, sneak up on you, and that's the problem, and they cause pain or they cause jaundice, and I mean, that's That's
Well, I'm not following you there at all, because when she first came, I don't know why she came in here in the first place. The doctor obviously referred her because he had some hint or suggestion. But Mr. Charney went through the process, and she had a pancreatic tumour.
yeah.
I mean, that was it from word go.
Well, I'm sorry, I can't sort of help you out there because I really don't know. I mean, much about her particular situation and the background and things. But certainly, I can say that yes, pancreatic tumors can develop without pain or jaundice. But usually, one of these two does happen. And I mean, in the absence of these two, for the pancreatic tumor to be diagnosed, I think it was. I don't know, was it a GP that sent her across?
Yes, yes.
They probably did a scan of some sort or something for something
Also
else.
a few scans.
Yeah,
That's quite a lot of scans.
Mm.
But she only had pain, as far as I was aware, the last 2 or 3 days in Shotley Bridge Hospital before she died.
I mean, if you want me to, I can sort of
She's dead. She's been dead 23 weeks yesterday.
Is it? I'm so sorry. But if you want to, I can actually investigate a little bit and sort of because I get the feeling that you haven't really got to know what exactly went on and things like that. Do you want me to?
She told the medical personnel in Dryburn when she first went for vomiting blood not to tell me what was wrong. They said that if they told me, they could be taken to court. So they told me nothing. She was transferred from there to Shotley Bridge to rehabilitate, to get her strength back to come home. In less than a fortnight she was dead. Some rehabilitation.
I know. I mean, it's,
and the only time she had that I was aware of was about 3 days before she died, where her skin was tended to touch, which you touched on in your talk.
Yeah. Yeah. Yeah.
Initially she was taken in because she was vomiting blood. Now that would be in this little notebook that you have here, that it does mention blood.
Yeah, but that's quite right. But I don't think I talked about various things in relation to sort of tumors of the pancreas and various other problems. I just only touched on the inflammation and the chronic pancreatitis side of things. But certainly, yes, tumors of the pancreas do tend to creep up on people, and they're usually quite advanced by the time we get to know of them. And treatment is possible, but but in a very small percentage of patients. That's because we really don't get to know about it until it sort of goes beyond something which is treatable.
She used to always be a little bit naive. She used to say, "Great big tumour." That's the way she used to say it. That's the way she was told in the Freeman year.
Yeah.
And then it developed from the tumour into the pancreas was covered with cysts.
Yeah. Yes, that can happen. That can happen because of a blockage of the main duct of the pancreas. It can.
But pain never came into the equation.
No.
I mean, when she first went to hospital, it was for vomiting blood. I most certainly expected her coming home, but she never came home.
I'm so sorry,
Perhaps we ought to then move to another question.
Yes,
Thank you very much for it.
I'm concerned about how long it's taking far too long for people to be diagnosed with diabetes, type 1 or 2. I've got 2 sisters with diabetes, both on injection, and now I found 4 weeks ago, this is only because I went to a doctor to get a flu jab, which I should have had. I'm 68 now, but that's the first one I had. And I had blood pressure, and then I started doing blood samples and things, diabetes. Now I've lost, in the trouble with not being diagnosed in all that time, the nerves have got on my feet. I feel like I'm walking on a sponge all the time.
Yes.
Nerve endings, eyes bleed, the classics. I've got 2 sisters with it. But why is it taking so long? Wouldn't you think doctors, GPs would see
I'm really surprised.
Not the only one, I'm kidding.
No.
Yeah.
You're usually supposed to have, at least once a year, have at least a urine sample tested for.
Yeah, nothing else.
For sure.
I've never had anything else at all. Is it a result? I'm attending 9 clinics. Yeah. From foot care on.
Yeah.
But it's taken far too long. Something's got to be done. And I think GPs are quite a lot to blame for this, because when it's in the family, they know, surely.
Well, there is a protocol, I'm sure, which most GPs usually tend to follow, that anybody over 40 usually has.
I'm 68.
Yeah, they should have. I mean, especially given the fact that, you seem to describe neuropathy and, which is a sign of you know,
Yep.
the fact that diabetes has been there for some time, you know.
Oh yeah, that's what it is. 20 years.
So I mean, it should have been checked out.
Yeah, well, I'm not the only one. There's 100,000 local in the northeast. And they're diagnosed. God knows how many are not diagnosed. You know, but certainly I think within the families there should be some kind of check on.
But there usually is. I mean, there are some types of diabetes,
Yeah.
you know, which runs in families. Yeah.
Both
Yeah,
systems,
you know,
one.
yeah. So, but I'm very surprised that the GPs don't take.
Well,
Maybe, you know,
the
that's-
result.
they say that they're overworked.
Yeah. Well, the result, I'm rapidly losing weight. You know, when we were sick.
Yeah.
Yeah.
Well, are you now on treatment now and
Medication.
Medication.
Aye. And diet and things like that. And oddly enough, I don't feel, not a hip of the difference that I have over the years. That's the only thing. I'm a gardener, you see, I'm a show, you know, I do garden shows and things. And I thought my foot trouble was to stand on spades. You know, did? Which, you know, all gardeners get that, so that meant nothing.
Well, yeah, that's one of the things, you know, you probably wouldn't find much difference by getting your blood sugar level under control. It's just going to prevent or reduce the effect of the raised blood glucose level on the various organs in the body. That's what it will do for sort of long term.
That's what I was sure advice. You haven't got running reserves. That was the advice I had. So I'm not going more meals, less at a time.
Yeah.
You couldn't know.
Yeah. That's it.
Thank you anyway.
I've got a question. I was pregnant last year. I've got hereditary pancreatitis.
Yes.
And I was pregnant last year and I had an attack. I was actually at the QE and I went to E&E at the QE and they gave us codeine, but that made us violently sick.
Yeah.
What else could you take when you were pregnant?
Usually, I mean, that's quite a tricky, you know, situation. How many months were you then?
I would have been 5 months.
Yeah, that's. I mean, some obstetricians and gynecologists, you know, what we tend to do in a situation like this is to just ring up the you know, obstetric on-call person and have a chat with them. Small doses of opiates seem to be okay. You know, so a little bit of morphine seems okay, just for the acute, you know. In the first 3 months of the pregnancy, obviously, you know, they tend to avoid everything. And then towards term as well, they tend to avoid, you know, because, you know, the various breathing difficulties with the kid and things like that. And certainly, they, you know, do not recommend, or they strongly are against giving somebody regular morphine during pregnancy because it causes, you know, long-lasting effects. So just a small dose, just for an acute episode, you know, when you've got pain and things like that, you know, I don't think there is anything to stop anybody from giving you a little bit more.
Right.
But it's always obviously got to be checked with the obstetric, you know, people who are around, and we usually tend to take advice from them.
Right.
And sort of, but it is a very difficult thing, you see. I mean, especially now with sort of us being aware of all the various problems that opioids can cause. You know, we are really wary about it because you don't. I mean, if it's for a young healthy adult, then it's fine. You know, but especially when when you're 5 months and when you're pregnant and things like that, you know, it's always careful to be cautious. You know, worthwhile to be cautious. But did it settle down with the codeine and with the sickness now?
It carried not really carried on.
Yes, because you see, the morphine also causes violent sickness.
Yeah.
And you end up giving metoclopramide or cyclizine, which is not really good, you know, for, you know, when you're pregnant. So you usually end up with something like ondansetron or something.
I wasn't hospitalised. I just came out of hospital and I took the codeine as and when. I only took it twice, and I was violently sick with it. So I just gave up and sat it out.
Yeah, you would have been probably better off just taking paracetamol, I suppose, isn't it? Yeah. When you're not admitted to hospital, you see, that's a completely different situation again. Probably just paracetamol.
Yeah.
You know, then nothing else. Certainly not long-term tramadol.
Also, with having hereditary pancreatitis, if my daughter ever does show any sort of symptoms and does get admitted to hospital, What sort of pain relief can they give to
Anything.
children that are...
Yeah, children can have morphine.
Right.
You know, if needed, children can have morphine. But children are usually pretty resilient, you know, and there are various things which you can do, like paracetamol can be given IV, which is absolutely fantastic. You can give paracetamol IV, and that really does wonders. I mean, unfortunately, there's another problem again in that, you know, you go to various hospitals, and certainly we use it here, and we use it in West Cumberland where I'm working now, and in various other hospitals. But in a few hospitals, you go and I mean, I've seen it during my rotation here. You go and you ask for IV paracetamol, and they look at you and say, you know, what, IV paracetamol? You know, it depends upon, you know, what sort of you know, stocking the pharmacists do, and if they've got IV paracetamol, and if they find it cost effective, and you know, various things. But IV paracetamol is very good.
Right.
You know, and there's no reason why kiddies shouldn't have any pain medicine which adults don't have. Obviously, apart from things like diclofenac and, you know, ibuprofen, because they usually tend to not give them for young kiddies. But again, you know, you've got to usually the pediatricians come in there, and you sit down and you work out the child's body weight and everything, scale that down, and the pediatricians usually get involved quite heavily.